All right, well, good morning and welcome to Unmute Your Probe. This podcast is from the ultrasound section of AAEM, and we're going to cover current controversies and research in point of care ultrasound. In previous years, Unmute Your Probe has been a lecture series focused on basic and advanced ultrasound modalities. All of those lectures are still available for you, and if you are a member of the section, you can get CME for listening to those through the ultrasound section website of AAEM, and I encourage you to check those out if you have any desire to learn about cool things like ocular ultrasound. Today I have with me Zach Boivin. Am I pronouncing your last name correctly?
Yes, you are. That was great.
Excellent. Um, Zach, would you like to introduce yourself?
Yeah, so my name is Zach. I recently completed an ultrasound fellowship at Yale and stayed on it as faculty there. I did my residency at UConn and along with medical school there. I really have a interest in medical legal aspects of point of care ultrasound. It all kind of started with reading the Bounce Back book series and then the L Word podcast, both of which are fantastic resources as a jumping off point. And now I just have an interest in general in how to limit medical malpractice lawsuits in my own personal management of patients, but also, helping other people through POCUS.
Well, awesome. That sounds pretty great to me. And the Bounce Back series was part of my residency curriculum. It was both terrifying and super useful. So yeah, I agree. Certainly agree with you on that one. Okay. So Zach, you sent me two papers that I had never read and were super interesting. And let's start with your paper on archiving images. I know I just spent 9 years at a trauma center, and trying to get images archived in the trauma bay was just this constant Sisyphean ordeal. Like we would succeed for a while, and then I would take my eye off it, and there would be no images recorded for 6 months. So tell me what kind of sparked writing this paper and a little bit about it. The paper, by the way, is Prevalence of Phantom Scanning in Cardiac Arrest and Trauma Resuscitations, The Scary Truth. You can find it in the POCUS journal.
Yes, so we actually, my in residency, we were looking for a residency project, and as I was going into ultrasound fellowship, I wanted to do something ultrasound related. We were doing a cardiac arrest study in traumas, and we found that a lot of the images weren't actually being saved when it came to actually looking at the FAST exams. And so that was a jumping off point of, hey, what is the actual prevalence that this is happening? And so we actually found that 70% of cardiac arrest scans at our institution, and this was my residency, not my current institution, were not being saved. And then that jumped to 86% when it came to FAST exams, which both are a scary number to not have images associated with them. And so we wanted to look at those high stress scenarios where providers may not click the save image button. And ultimately, we figured out that that's such a high number that we need to address it somehow.
Mhm. Tell me a little bit about the workflow. So you said this study was done at your residency site. I
Yeah.
noticed in the paper that it seemed like there was a way to save anonymous images and put them in the patient's EMR later.
Yes, so the workflow was order-based, meaning that the patient has to be registered, you put in a electronic medical record order, and then on the machine itself, you pull up their name. But in the case of a trauma or a cardiac arrest where there wasn't really time to register the patient, if you just clicked save image, it recorded under a temporary identification, which could then go to the PACS system and then be changed later to match up with the patient. So even when we kept telling people as an educational thing, like even when you don't have the patient's name in there, still save an image because we can find evidence of that later on by just looking at the PACS at the time that the ultrasound was done to match that up with the patient.
Yeah, that stood out to me because I think that's probably the best case scenario. I know most of the hospitals I've worked at, we haven't had that. If there's no order and you can't save the images. And so traumas particular were always an issue because we would get a fair number of folks that just kind of showed up. So to me, that says even in the best case scenario, we are barely saving half of these images. Now, you and I are probably already sold on the importance of archiving images. But why don't you tell us a little bit about what you think the medical legal risks of not archiving those images would be?
Yeah, so I think the biggest medical legal risk in terms of not archiving images is the fact that if a case was to go wrong, there really isn't any evidence of the exam that you performed. For example, if a radiologist was to be named in a medical malpractice suit because of their misinterpretation of a CT scan, well, you could just look back at that CT scan in the PACS. But if someone was to raise a lawsuit that states that, oh, I misinterpreted this FAST exam, and then you went back into the record and couldn't find any evidence of that or any archived images, it would be a little difficult to defend yourself even if you did do the exam perfectly correct and interpreted it correctly. And in general, you also do need a saved and archived image to bill for the exam. And so you want to make sure that if you start billing at your institution for point of care ultrasound, that there is a way to save and archive the images. But for
Yeah.
me,
Mhm.
honestly, archiving images was more important for patient care because consultants, if you archive the images, a lot of times consultants can see those images. Hopefully, it gets uploaded to the PACS. And then also, as ultrasound faculty, when we go to QA/QI, we can't give feedback on those images if they're not archived. So I can't say, hey, next time you would do better if you caught the liver tip in this FAST exam to make sure that there was no free fluid. I can't do that if there's no saved image.
Can you give any examples of cases where you think not having saved images impacted patient care?
So I think ultimately fast exams are the big ones. So, we talk about there's there's the case where it could be a false negative fast exam where you say that there's no free fluid and then they go to CT, for example, and there's a large laceration and the argument is, well, the patient was hypotensive, you should have seen this on fast exam. And as we know, the FAST exam is dynamic, so it could have completely changed. And that's why I'm a big fan of just repeating the FAST exam, especially if the patient becomes hypotensive. And so I can see that as a situation as where the trauma team and there's some disconnect between the trauma team and the person performing the FAST of, hey, you should have seen this. Whereas if you save the image, you can say, hey, look,
Mhm.
it wasn't positive at this point. Maybe it's positive now.
Yes. And I'm realizing I never introduced myself. I'm Melissa Myers. I'm an associate professor of emergency medicine and one of the board members for the ultrasound section. And yes, couldn't agree more. I know we had many cases where myself and the trauma team would discuss, was it a false negative fast or was it just negative because the patient hadn't bled enough yet for there to be a positive fast? And it was always very difficult to defend an emergency medicine physician if there's no images because the assumption will be that you made a mistake. And I want to share one more example from residency. This wasn't my case, but I think it terrified all of us enough for me to remember it 15 years later. We had a patient come through the emergency department who had a pericardial effusion, and nobody disagreed that there was a pericardial effusion. He got admitted. He was stable when he went upstairs, went to the floor, went into tamponade, had a code blue, ultimately did fairly well, but there was this huge discussion of whether or not there had been signs of tamponade on ultrasound in the ED, and unfortunately, the images weren't saved. I still to this day think he probably did not have those signs based on how stable he was and the time between going to the floor and his cardiac arrest. But with no saved images, the presumption is always that they were there and we just missed them. So yes, couldn't agree more that archiving images is protective. One thing that I'm told occasionally by other physicians, and I'm curious your thoughts on this, is they don't want to save the images because they don't want proof that they did it incorrectly or missed something. What are your thoughts on that?
Yeah, so I have heard the same thing. As part of the study, it didn't actually make the study for the phantom scanning, but we actually had an abstract that included a survey on why providers didn't save their images. And that was one of the popular responses, not the most popular. Usually it was lack of time in cardiac arrest and trauma.
Mhm.
But my response to that is genuinely that, you can get sued for the most innocuous patient presentation.
Mhm.
And so by not saving the images in general, you open yourself up to just any patient having come back with a bad outcome, even if it was something where you were like, you know what, I did it. It was a totally normal exam, so I'm not going to save it because what if I missed this little thing that, I wasn't even looking for? Another thing is that, ultimately, point of care ultrasound is a focused exam. And I've heard a lot about what about incidental findings? So for example, if you do a biliary ultrasound and you don't happen to notice that there are some masses in the liver, and then the patient doesn't get a diagnosis because of that. Well, I do think that it's defensible given that when you're doing a biliary focused exam, you're just looking at the gallbladder. And so I do think that, saving those images is important for the medical record, but also I think that, ultimately a radiologist doesn't, throw away a CT scan if it's negative. They don't, delete an X-ray, a chest X-ray if it looks reassuring. And ultimately, this is a, it's a study that should go into the medical record. And it's an extension of the physical exam. So it's more than just the physical exam. It's actually a procedure on the patient, and that needs to be saved.
Yeah, I agree. We don't balk at saving our intubation videos. We shouldn't balk at saving our ultrasound imaging. I know when it comes to the incidental findings that I've had similar conversations, including with radiologists, and I generally tell them what I tell my patients. This is a focused exam. It's not a complete exam. If you continue to have symptoms, I'd recommend you go get a complete exam down the road. Awesome. So what do you think? I think this is obviously an issue, and I think it's probably much more widespread than just our two institutions. What are some things that you think we could do to decrease the amount of phantom scanning we see?
Yeah, so after we found that data, we are trying a few things at the institution to try and decrease the phantom scanning rate. One thing was just sticking a sticker on top of the machine, like right where you would have to look if you're trying to interpret the images, that said hit the save image button even if the patient identifiers are not in, just so that we can capture anyone when the probe is on the patient. But ultimately, I think that it comes down to education of, attendings, education of residents. Anyone who is using the ultrasound should have the expectation that if the probe touches a patient, an image is saved. And that should just be a hard stop, no exceptions. And so, one thing that my current institution has done is they actually locked down the machine for username and password. So you have to log into the ultrasound machine with your Epic credentials. And so by logging into the machine, it understands that someone who knows how to use the machine is performing the exam, or at least overseeing that. Because one of the things that happened at our institution was occasionally the trauma team would want to do the fast exam for practice for their surgical residents, or when the EM residents were at conference. And in talking with the trauma team, no one really knew that we were supposed to save images or even how to save images. They just knew how to get the views on the fast. So I think it's education of anyone in the emergency department who's going to be using the ultrasound. And in addition, people have said in the past, like, one thing that we talked about with this was, well, would an encounter-based workflow change anything? And then encounter-based workflow is basically where every single person already has an order for the ultrasound, and you just have to find their name. But, that still doesn't overcome the fact that someone has to press the save image button on the machine. So, because even when we had the patient having been there, having been registered, we were still seeing images not saved. So it's not just a workflow thing. I think it starts with education of everyone who's going to use the ultrasound, that the second that the probe touches the patient, you need a saved image.
Awesome. Well, I'm glad you shared your paper. I may or may not have already sent it to a bunch of my former fellows uh, as a example of why we should be saving our images, and that this is a widespread problem. Before we move on to your mildly terrifying paper on medical legal risks, do you have anything else that you want to say about this paper?
No, I
Or
think that the paper was a great project, but it's only one center. So actually what I'm working on now is working with a couple of different institutions to figure out, what the rates are at other institutions and how they differ. Because my hope is that the institution we did this at is on the high side, but I want to see kind of where others fall. Because there's never going to be 100% rate in a cardiac arrest or trauma. It's occasionally going to fall off, but we can get as close to zero for phantom scanning as possible. And if we figure out how widespread the problem is, then we can look at potential solutions and see how those work at more than one institution.
Anecdotally, I think your residency institution was probably top 10% for number of saved images, but that's just anecdote. All right. So the second kind of paper you sent me was almost an update to a previous paper. I had intended to discuss an article from West Gem titled A Review of Lawsuits Related to Point of Care Emergency Ultrasound Applications, which I've used for years for my residents and fellows. And I always liked it because there were no cases in there where performing ultrasound led to a lawsuit. It was all cases where not performing an ultrasound. So specifically not doing a DVT scan, not doing a timely gallbladder scan, failing to perform a fast exam led to a lawsuit for a missed or delayed diagnosis. And I sent you that paper, and then you sent me back one that had news that I was not happy about, but I'm glad to know. Wherein there were multiple cases where an incorrectly performed POCUS led to ultrasound. And that paper was Medico-Legal Risks of Point of Care Ultrasound, a closed case analysis of Canadian Medical Protective Association medical legal cases in the Ultrasound Journal. So tell me a little bit about that paper.
Yeah, so that paper I actually stumbled upon. I followed the author on Twitter and they tweeted it out. I read it and I immediately replied to them because I was like, this is the first paper that I've seen where POCUS, having performed a POCUS, was a problem in a medical malpractice case. And so, I went back and forth a little with the author and yeah, he agreed, this is the first evidence that, you know, having performed a POCUS resulted in, well, it not necessarily resulted in the case, but it was a part of the case. So, initially I was the same way. There were a couple of cases, a couple of studies. The one that you had talked about by Stoltz et al., that was 2015, using the
Mhm.
Westlaw database. And then Russ et al. In 2022 updated that paper. So used the same database, but did 10 more years of that. And they both found between the two of them, there were 25 cases, and literally none of those 25 cases that mentioned ultrasound had a point of care ultrasound performed. And it was usually the fact that no one performed the ultrasound, as you mentioned, that was the reason ultrasound was brought up. But the study by Prager et al. Basically found 15 cases where POCUS was a part of, and 7 of those cases were very similar to Stoltz et al. And Russ et al., where there was no POCUS performed at all. But ultimately, there were 8 cases where POCUS was actually, a part of it and it was performed. So a few of those were, images that were inadequately obtained. One of them was inappropriate use of ultrasound, and 3 of them had no report in it, which I'm not sure if they were pretty vague about it in the paper, but I'm not sure if that was that the images weren't there or there wasn't actually documentation that the POCUS of what the results of the POCUS were. But ultimately, this paper kind of brought up the issue that, hey, performing a POCUS is not this magical get out of medical malpractice free card.
Mhm.
And, one of the issues with the databases of cases that were used for prior studies and even the study by Prager et al. Is that most of the legal, from what I understand, I was kind of looking around at this, was that to get into one of these databases, you really have to reach a level of filing with a court, which is kind of a survivorship bias in my mind of point of care ultrasound, cases. Because in my opinion, if you misinterpret a point of care ultrasound and you get sued and there's evidence of that misinterpretation and your hospital or your lawyers feel like they can't defend it well, it's going to settle early on, and that won't make any of the databases that are studied. So it's almost like you have to survive to feeling that it's defensible, and then you make it to court and then you make it into the database. So, I think that there are some more cases out there of false positive, false negatives leading to delay or misdiagnosis. But that doesn't mean that you can't use POCUS. That doesn't mean that you should be scared of POCUS, because ultimately there is, you know, for me, I've definitely just found multiple evidence of multiple things that I wasn't thinking of on point of care ultrasound and making diagnoses in a timely manner that I would not have made as timely without POCUS. But ultimately, it's not this get out of jail free card where by performing the POCUS, you automatically exclude any risk of medical malpractice.
Mhm. earlier you equated POCUS to procedure, and I think this comes back to that. It's a procedure and it needs to be done correctly. And if it's not done correctly, then there is risk, as there is with any procedure. I wish they had given more details on the cases where POCUS was used and it resulted in a legal settlement. One of the things they mentioned was misinterpretation of images. And then specifically in the discussion, they talk about the FAST exam. And it reminded me a little bit of your archived images, because I know a conversation I've had with my residents, my co-attendings, other consulting services, is that a FAST exam is not a CT. A negative FAST in no way rules out intra-abdominal hemorrhage. And I couldn't help but think about that when I read this case, because that's an example of ways that I've personally seen ultrasound used that I thought was not correct and could lead to a bad outcome. Could you give any examples of times when you think it'd be easy to misinterpret or misuse POCUS?
So one of my pet peeves is that every pregnant patient needs a point of care ultrasound. And I can see an ectopic pregnancy being missed, especially a ruptured ectopic where they don't look for free fluid in the right upper quadrant. There's been studies that show that that really predicts need for operating room time. And I can see places where if they don't have radiology overnight, they kind of sit on the patients or they discharge them for outpatient follow-up, having not seen a definitive intrauterine pregnancy and not notice that there's some free fluid and that there may have been some free fluid in the right upper quadrant. In addition, you talked about a tamponade case, right? You know, if you don't put a probe on the patient's chest, how do you know that they don't have a pericardial effusion? And then once you identify a pericardial effusion, how do you rule in and rule out tamponade?
Yeah. And the other thing that struck me about this paper is, I know we all want to do the fancy advanced modalities. Wall motion abnormalities comes to mind. And I think that there's some risk there if you don't have extensive training. I know, talking to the cardiologists, their version of an echo is very different than my version of an echo. So, for example, I'm fellowship trained. I've got a designation of focused practice. I don't do valvular pathology. I don't feel that I'm adequately trained or that it's within my scope of practice. And I think it's very easy with the echo or with other exams to get into areas that we shouldn't be in and that are beyond the scope of practice of an emergency physician. Do you have any thoughts on that particular topic?
So, I mean, I think that just like a procedure, because this is a procedure, you have to know your limitations. And, that's a great point about valvular pathology. I do the same thing. I don't do a lot of valvular pathology unless there's, like, for example, obvious tricuspid regurgitation in a patient with right heart strain, but
Mhm.
that's only like an addition. That's that next level. I think that ultimately, just as there is anything else in medicine, people have to know their own limitations. So my limitations and your limitations are different. Someone listening to this, their limitations may be completely different. So I, for example, have access to 24-hour ultrasound. So if a patient comes in with testicular pain that I want to do a testicular POCUS on, I will do a testicular POCUS. I did one last night on shift for a 7-year-old who came in. But I am still going to get that radiology image. So you have to know
Mhm.
your limitations. Also know when you even like, if you do, for example, I do a lot of gallbladder ultrasounds. We had to do a lot in residency, so I'm very comfortable with it. I understand that if I don't get good views of the gallbladder and the patient still has pain, that I need a complete radiology exam for that modality. Or if I'm having an indeterminate exam, if I'm sitting there hemming and hawing over what I'm seeing, I'm going to try to get a confirmatory exam to make sure that I'm in the right. And, I don't think that it's, that means that you shouldn't do POCUS if once in a while you have to, you have an indeterminate exam or you want to get a complete follow-up radiology exam.
Mhm. I agree. It all comes down to knowing the test characteristics of any test that you use, which would include POCUS. And I'm the same as you. I do a lot of gallbladder studies. It's one of my favorites. And
Yes.
every once in a while I do it and it's negative, and I just really don't think it should be negative. And when I remind myself that the sensitivity is 88%, and I go get a different study. Sometimes radiology finds gallstones, and then I'm very sad inside, but I'm happy that I made the diagnosis. So, all right. The last thing that I wanted to talk about was the handhelds. and how we are incorporating those into emergency departments, because I think there is a lot of legal risk there. And it's still a little bit of the Wild West with how we're using these things. So I know I have a butterfly. I don't use it at my main site, either of my main sites, because we have hospital rules about taking in outside machines into the emergency department. What do you think about the handhelds? What risks do you think we have with those?
Yeah, so the handhelds are great. They're amazing for teaching. And that's kind of teaching in global health is kind of where I see the main uses for those because, for example, if you're teaching medical students, you're not really saving and archiving images, you're, scanning normal people. And so you can use those handhelds in order to increase the amount of ultrasounds and the amount of hands-on while decreasing the overall cost. Because the cost of 20 handhelds is equivalent to the cost of one cart-based machine. And so you can educate a lot more people with handhelds. And in the global health environment, you can go and bring these handhelds, you can bring them on a plane, you can bring them to areas and start educating people with lower cost ultrasounds as opposed to the cart-based.
Mhm.
But just like your institution, my institution does not let you, if you bought a personal handheld ultrasound machine, they do not allow it to be used unless they like go through a very serious steps of, you have to archive the image. It has to archive the images within our system. It has to be, approved by IT. It has to be approved at like every level of the institution. And so it really doesn't, it's really a lot of paperwork to get your own machine.
Mhm.
And then you have the risk of, well, if I'm using my personal phone with it, do I have data on my personal phone? Do I have patient data on that phone? And ultimately, if I lose that phone, am I responsible for a potential loss of that personal data?
Yes, there's definitely some risk there. You're certainly not incorrect about global health, though. I know I've done several missions in Honduras and Guatemala where the handheld was amazing. It was perfect for that environment because I could put it in my backpack, and the backpack was what we were using to transport between sites. But I don't use it here where I have access to the cart-based machines that can archive images. That was the last topic that I had for today. What else? What like burning things would you like to say about legal risks with POCUS that we have not talked about?
I mean, I don't think I have anything specifically burning, but I think the overarching thing is that I don't want this to scare anyone from performing an ultrasound because I do think, there are so many cases where I have found something or, our team has found something where we weren't expecting it. So for example, Gail has a rule, we do stress tests inside the emergency department, but to get to a stress test, you have to have an echo. And multiple times, with recently, for example, we found a tamponade in a patient who was not expected to have a tamponade, who was supposed to go to the chest pain center. So that person ended up in the cath lab for a drainage. And we have found multiple dissections in people who, have, were supposed to go to the chest pain center for a stress test. And so, ultimately, I think that the research rings true that most of the time, your risk increases if you're not performing an indicated point of care ultrasound. Because if you are worried about something like an effusion and you put the ultrasound down and show that there's no effusion, then it decreases your medical legal risk because now you've ruled something out. But at the same time, I want people to understand those limitations because it's all about your limitations. If you go rogue and start diagnosing, aortic stenosis on your ultrasound and then aortic regurgitation, then it's, you have to be right. And, ultimately not everyone has the same threshold for doing a point of care ultrasound. And then once you do a point of care ultrasound, people have varying levels of skill. So don't shy away from the ultrasound because you feel that it's going to increase your medical legal risk. Because ultimately, every single patient that comes in the emergency department, there's some degree of medical legal risk from every one of those patients. And POCUS has been proven based on the fact that even with all of these studies, we've only really found 7 cases where it was involved. And the vast majority of the time, it's going to be you not performing the point of care ultrasound. So I do think that there's still a huge protective effect of performing point of care ultrasound, But as we talked about, kind of knowing your own limitations and knowing when to get that confirmatory image with either a CT or complete radiology ultrasound is so important for your own medical legal risk protection. And you got to save the images so that if something bad happens, you can back yourself up by saying, look, these are the ultrasound images that I did. It didn't show a positive FAST at the time.
Mhm.
And so overall, I want people to not be scared of point of care ultrasound. And I do think that it helps significantly reduce your medical malpractice burden and risk.
Well, thank you so much for taking the time to come on and be recorded this morning. This has been Unmute Your Probe, a podcast from the ultrasound section of AAEM. We're going to be releasing episodes monthly. Next month, we are talking about transesophageal echocardiograms in the emergency department, when we should do it, when we shouldn't do it, and what we should be looking for when we perform these exams. Thank you everyone for listening, and I look forward to talking to you again next month.
We hope you have enjoyed this podcast from the American Academy of Emergency Medicine. AAEM is a nonprofit professional association of over 8,000 emergency physicians dedicated to board certification and democratic group practice. For more information about AAEM, visit our website at www.aaem.org.